Well, welcome again to everyone on Ask the Orthodontist. And this time I have a world-renowned pediatric dentist who's going to help explain some of the questions that parents have asked me along my journey. And it's great to introduce Dr. Alison Sigal. She's a certified specialist in pediatric dentistry and the founder of Little Bird Pediatric Dentistry in Milton, which is in Ontario, Canada. She completed her honours degree in kinesiology at McMaster University and then earned her Doctor of Dental Surgery degree from University of Toronto and finally completed a hospital-based residency at Mount Sinai Hospital in part of her completion of her Masters of Science and then specialty training in pediatric dentistry. She's a fellow of the Royal College of Dentists of Canada. Um, Dr. Sigal has dedicated the past decade to advancing airway-centric healthcare through clinical practice, not only from the numerous patients she's seen, but from her research, her education, and innovation. She's developed novel airway assessment tools, which we'll discuss more length today, some newer surgical techniques for tongue, and she's been doing this while building one of the world's largest ongoing centric clinical databases. Um, her peer-reviewed research on the tongue as a muscular hydrostat has helped advance the understanding of tongue function, tongue resting posture, and the role of tongue tie in breathing, growth, sleep, and overall health. Her career goal is to help make airway-centric assessment and treatment the standard of care from birth onwards. So in terms of topics, if it's okay, Sigal, we would really like to focus on helping parents understand some of the most common questions around tongue ties, right? So if I can
You bet.
kick off by asking you, when would you say a tongue tie should be assessed?
Great. Well, first of all, thank you for having me on your podcast. I greatly appreciate it, the international collaboration. So, to answer your question, when should a tongue tie be assessed? And this, as you just mentioned, is one of my career goals, where what I'm advocating is that as soon as babies are born, so when a baby is born, as part of our checks of their auditory, their hearing, their APGAR, we give them their vitamin K shots. We should be assessing their mouths and their tongue function. So lifting their tongue and assessing for tongue tie. So before a baby is discharged from the hospital or from wherever they were born, as soon as possible, because we know the most rapid time for their growth and development is the first 2 years,
Yep,
where we want the tongue able to do all of its important roles, which unfortunately are not well known by the public.
yep,
That's something that we're
yep.
working, you as well, every day on advocating, so that the child has optimal anatomy, that they are then on the optimized path, as opposed to having to compensate around a tongue tie, tongue restriction, that everything then has to work in a different way.
I remember listening to your excellent lecture for the Ontario Dental Association, and you were comparing a lot of good statistics out of Brazil to your own practice. One was, I think,
That's right.
percentage of kids who had mouth breathing. So Brazil seems to be a leader in this, what's the word, interceptive preventive approach. I know there's a national frenulum law in
Hmm.
Brazil. I wish it's the same in Australia. Unfortunately, in Australia, it's kind of when I see a 7-year-old who's so tongue-tied, I say, well, no one ever brought this up to you, and they say, oh, with the midwife kind of mentioned it, but then he was feeding okay, so we didn't do anything. There's
That's right.
no, yeah, there's no sort of black or white guidelines, and I think what you're doing is great in that regard. So parents
Yeah,
know that someone's actually gone through the motion, and rather than just subjectively said, oh, maybe, maybe not, measured it, right? Um,
that's right.
but let's talk about tongue tie releases if we can hop straight into that. And I think the
Sure.
question, and I'm just posing questions that parents ask me,
Yeah.
and they ask, are all tongue tie releases the same? And if they're
Yeah.
not, can you explain the differences?
Yeah, absolutely. So I wish I could say yes. That is the hope for the future. So as you just alluded to, no matter where you are in the world, whether you're Australia, whether you're Canada, Europe, there's no standardization of tongue tie, anything related to tongue tie, how you assess it, how you diagnose it, how you treat it, the post-operative care. So that's what makes it, quite controversial. And unfortunately for the families, it makes it very confusing because whoever you go to, you're getting different information. Someone's telling you there is one, someone's telling you there isn't one. And then in terms of the releases, there being no standardization of releases, and it's not regularly taught in our curriculum, which I can speak to in Canada, regardless of your background, whether you're a oral surgeon, a pediatric dentist, a plastics, ENT, the curriculum has not evolved. So still we're being taught if you can stick your tongue out past the, lower edges of your front teeth, you don't have a tongue tie, which is completely not true.
Right. Yeah. Yeah.
So in terms of tongue tie releases, if we're basing it on that information of what we were taught, many people are doing what I call partial releases, which means
Mm.
they see a tongue restriction and whatever method they're using, they're releasing some of that and they're getting more mobility of the tongue. So the tongue
Yeah.
is able to move more. They can visually see that it's moving more. They think, I've released the tongue tie.
Yeah.
But that's what I call a partial or incomplete release. And it's, no blame to the provider. Everyone's doing
Yeah.
the best they can with what they know. We just now need to get to making the standards of care where the difference of a partial release to a complete release. Now, what does a complete release look like? That looks like releasing that restriction so that the tongue can fully separate from the floor of the mouth. So the tongue should be able to lift 100% straight up. This is the tongue, and that's the floor of the mouth. Should be able to
Yeah.
separate fully. And
Yeah.
when you have that separation, that allows the tongue to naturally, all by itself, suction up and stay up against the roof of the mouth. And that is the critical aspect, and what all improvements are based upon is
Yeah.
attaining that 100% of the tongue naturally, just like a suction cup, just like a tentacle of an octopus. That is what the tongue is. It's a muscular
Yeah.
hydrostat to suction up there. But because very few providers are releasing enough to unlock that 100%, they aren't getting those full improvements. And that's where we have very mixed results where some providers will say, "Oh, I don't really see any improvements." Or,
Right. Right.
there's been no changes. Oh, I tried that, but nothing happened, so there must be other avenues. And unfortunately, a lot of the families are, they think all the releases are the same.
Yeah.
So they'll say, "Oh no, I had a release," but the child's still presenting with every sign and symptom.
Yeah.
You
Yeah.
look in the mouth, you try to separate the tongue from the floor of the mouth, there's no separation. And
Yeah.
so, we're the bearer of bad news quite often, but it's validating for the parent because when the parent knows, oh my gosh, like there's a reason for all of this suffering, all this compensation, all the signs and symptoms, which I'm sure we'll get into today.
Yeah. Yeah.
And it can be easily fixed.
The way you describe the suction cup is really, really good. And I think one thing, Dr. Zaghi, we've invited out to Australia a number of times, and he's probably the
Right,
first person, certainly in Australia, to educate dentists and other oral health professionals, lactation consultants, etc., on the importance of looking for posterior tongue tie. Because remember, to get that full muscular
right,
hydrostat that you nicely have said, it can't just be the front of the tongue that it can
correct,
release, right? Um,
correct, yeah,
and again, we have three types of dentists in Australia. Those who just don't bother looking at the tongue, like literally, I'm
hmm,
embarrassed to say that, right?
yeah,
Um, they have a periodontal probe and they have their little explorer to look for cavities, and they do what they would, and they take bite wings every 6 months, but they don't bother looking at this, right? Then you
okay,
have those who actually get it a little bit, but are only focusing on the anterior component of the tongue. Like you said, like, can you poke
right,
your tongue out? There's all sorts of old wives' tales. Like, can you put the tip of your tongue to touch your nose? I mean, like, really,
yeah,
I'm not tongue tied, but I can't do that, right?
yeah, yeah,
Um, and most importantly, then you have the third dentist who's bothered to do postgraduate courses, who really understands and has a friendly inspection for all their new patients, and then has to explain to the parent what you said. Look, you've had a tongue tie, but there was no myofunctional therapy, so there's probably some, um, uh, you know, um, reattachment. And on top of that, let me explain to you about how the back of the tongue doesn't elevate, right? Now, Zagi,
Hmm.
as you know, is very big on putting his finger on the floor of the mouth so the kid can't cheat and sort of elevate that part, right?
Hmm.
And then he tries to get the patient to do effectively your suction hold, which I think I don't know what they call it. It's called like the clucking noise. And then if they see the posterior part of the tongue has a V, right? Then but can you maybe expound with your experience? How could a provider backslash someone in the healthcare field, how could they look for a posterior tongue tie?
Yeah. Well, I'm so glad you actually brought up this topic because one of my big advocacy um, stands right now is that I feel that there's so much arguing and disagreement about diagnosing. Is it an anterior tongue tie? Is it a posterior tongue tie? Is it a submucosal tongue tie in terms of the
Yep.
ones that aren't very visible until you lay hands underneath and really you can palpate and you can feel the restriction, but you
Yep.
don't see it visibly. And where I'm coming in is, to be honest, I don't care which one it is because they
Yep.
all are going to give that patient compensations and prevent their signs and symptoms. So
Yep.
across any tongue tie, what anterior, posterior, submucosal, the key is when you put your hands in the mouth. So the examination has to involve a hands-on component. You can do also, adjuncts, lifting the patient's tongue up. Can they bring their tongue back? Can you see a flat floor mouth? Can they stick their tongue out? You can do all sorts of aspects, but the key one, if you had only time to do one, would be two fingers, index fingers in the mouth, underneath the tongue, lifting the tongue up. And that tongue, as I mentioned before, it should go all the way back. Like you're literally able to extend the tongue
Right.
and you
Right.
can truly see and appreciate the flat floor of mouth. So you
Right.
have that separation. If a
Yeah.
tongue can do that, there
Yeah.
is no tongue tie. That
Okay.
restriction is gone. And when that restriction is gone or not present at all, the tongue will be able to act as that natural suction cup, that muscular hydrostat, and do the
Mhm.
suctioning up. But
Mhm.
if
Mhm.
you're putting your hands under and you cannot achieve that full separation, then there is a restriction. And so
Right.
what I'm the advocate for is so many providers of different backgrounds will say, "Oh, it's not in my scope of practice. I can't diagnose a tongue tie." And I say,
Yeah.
"No problem, but you and every human in the world can assess a tongue tie."
Oh yeah.
And,
Yeah.
and even my 8-year-old daughter, her in her grade two class, she comes home, Mom, 8 of the kids have tongue ties because she went around, can you lift your tongue up?
Yeah.
It's a
Yeah.
very simple assessment. And that's where if we can advocate that and get that awareness out, that
Yeah.
more power to the public
Yeah.
and parents, they know their children better than anyone.
Yeah.
So if you give that information to a parent, any parent can go home, can I lift my child's tongue up? And they
Yes. Yeah.
can't.
Yeah.
Then they can go on, like on our website, we have self-assessment checklists of all the age groups, where if they then answer yes to many of those things, those signs and symptoms are related to a tongue tie. And with complete care, release of it, and depending on the age, whether myofunctional therapy or not, because babies and children, teens, adults, they're all kind of treated differently.
Yeah.
Um, those things improve. And we're talking very quickly. So within, I see patients, my children, teens, and adults, I see them 8 days post-release, and we have 90% improvements across the board. So
Wow.
it so releasing a restriction completely
Yeah.
always seems to be an opportunity for things to get better. Like I've cared for over
Yeah.
4,000 patients. I have yet to have a patient, and I don't plan to have a patient that goes backwards.
Yeah.
It only seems, and that is because I believe our anatomy gives us answers to many questions. And, why do we have the folds and valleys of the roof of our mouth? No one really thinks about that. Well, it creates the necessary space for the wet tongue to
Mhm.
suction up against. You need that little air pocket, just like
Yeah.
a
Yeah.
suction cup that you have in your hand. You lick it,
Yeah.
needs to be wet, and you stick it. The
Yeah.
tongue, and so if you trace the whole folds and valleys, the rugae, we call them, all the way
Yeah.
back, it literally tells you where your entire tongue should be held.
Right.
And and it's a beautiful thing when it's
Yeah.
up there doing all the things it's meant to do.
I know
Yeah.
in my orthodontic career, there was always debate about expansion of the palate, right? And there still is
Right.
today. There's
Of
again,
course. Yeah.
there's extremists who say that's rubbish, it's never going to work, and then there's other people who expand everyone, right? Um,
Right.
and to me, there's no rule book. But one thing, as my journey along this tongue position has gone, to me, when I say to a parent, listen, I can tell if your kid needs arch development by getting them to do exactly what you described. Let's put your tongue up there, and the tongue is wider than the molars. The tongue doesn't sit within that arch frame, right? So then I
Right.
say, well, look, this is our goal. I think your kid does need expansion. And when am I going to stop expanding? When there's room for the tongue. And then what's going to retain my expansion? The tongue. So
That's right.
if I'm an orthodontist and I'm developing the arch around the tongue, the one thing I don't want is the inability of the kid to raise the tongue, right? So that brings me on to my next question. Parents do get confused. What comes first? Do you expand the jaw? Do you release the tongue tie? Do you do myofunctional therapy? My adage has always been expand, release, retrain, right? Like sort of make the room, get the tongue up there. But of course, it varies from age to age. And any thoughts
Totally.
on because I see this on all the social media groups for parents, and they're all confused because an oral myologist said you need to do this, this, this. Orthodontist said you need to do this, this, this. Pediatric
Right.
dentist said no, you need to release the tongue. Can you give us a syntax of care for the parent who
Yeah.
say has gone home and has yes properly diagnosed from your excellent charting
Right.
that their kid has potentially a tongue tie? Then what? What's the next step practically?
Right. Right. And this is, I would say, a complex question, right? Because as you know, with patient
Yeah,
care, everything's individualized, right? And I don't think there's a right or wrong, but I can tell you in terms of my experience what I often see in my practice, because my whole practice is dedicated to airway assessment, tongue tie, and myofunctional care.
yeah,
So when I see a child, so first it depends on the age, right? So if we're talking little people, like they don't yet have their adult four top teeth or adult four bottom teeth, they don't have their adult first molars, so they'll have all their baby teeth. Those kids, if their palate is narrow, I know that with a complete tongue tie release, I get the tongue fully up there
yeah,
paired with a myofunctional appliance, such as an example would be the MyoBrace, for example, which is an
yeah,
Australia product.
yeah,
When
yeah,
the tongue fully engages that MyoBrace post tongue tie release,
yeah,
we see incredible changes and quickly in terms
yeah,
of palatal expansion and
yeah,
natural palatal expansion, right? Because it's the tongue and the musculature that's engaging that myobrace appliance that's then allowing for that expansion. So we're talking
yeah.
every 3 months we see the child back. We take
Mhm.
pictures, we do measurements of intermolar between, whatever molars we have. So for the little guys, the baby second molars and the canines as well. And we see
Yeah,
beautiful expansion. So the,
yeah,
the the joy of being in pediatrics is that most of my patients are like paper mache, right? Like
yes,
they're
yes,
they're easily shaped and molded as long as they
yeah,
have the appropriate forces going in the appropriate
yeah,
places.
yeah,
And because my surgeries are with the children asleep, I can fully evaluate that tongue naturally suctioning up and
hmm
maintaining that position because they're under sedation. And that you only can truly fully assess if someone is asleep or under sedation beyond infancy.
yeah,
So for
yeah,
that age group, I believe in tongue tie release and removable myofunctional appliances for the
yeah,
most part because I
yeah,
see remarkable changes. But then if
right.
you're getting to the older kids that are having, now they
So
have,
if I just add something on that age group, I guess what
sure,
you're saying then, in the 0 to 6, let's say, the tongue is the
yeah,
expander, correct?
exactly.
Yeah,
Oh,
yeah,
yes, very
right,
much
yeah.
so.
And I know
Yeah,
Chris Farrell, who's a good friend of mine, developed the Maya brace. He was very influenced by Frankel's research, and
right.
keeping those cheeks away as that tongue sits up there. Um,
Yeah,
and I, again, I think I said this before we started the interview. I was very anti early treatment because, of course, in my orthodontic residency, I never saw a kid in primary
right.
dentition. I'd laugh if a 4-year-old was booked in to see me for
Yeah,
an orthodontic. Now it's the other way around because,
yeah,
I realized that that early development, that proper position of the tongue has a huge impact on breathing, on facial
Yes.
growth, on the
Yeah.
sleep and development, overall quality of life. And in Australia, we unfortunately are the number one provider of Ritalin per capita than any other country in the world. I mean, it's
Oh
crazy,
no. Yeah.
right? And people, I really feel if you can get at that, I love talking about 0 to 6, right? The brain is
Yes.
at its maximum size at 6.
Yes.
And if you really want to give that kid, I guess I use the term a healthy start in life,
Yeah.
100%, getting that tongue up there, teaching them how to breathe through their nose. And later on, I'm going to ask you some questions on your excellent, um, you know, slide that you put up for comparing your practice to the research in Brazil about percentage of kids who mouth breathe. Because in Australia, let me
Right.
tell you, it's more unusual to find a kid who doesn't mouth breathe. Does that make
I
sense? It's like,
know. Yes.
right?
Yeah.
And thank God for books like James Nestor, etc., that parents are really focused now. Parents come in saying, "Hey,
Yes.
my kid's mouth breathing,"
Yes.
and it's almost like it's forcing the dentist to kind of like AI search. Oh my God, is it bad for a kid to mouth breathe? Because
Right. Yeah.
uh, yeah, so I love the fact. Yes, my brace and Chris Farrell hopefully will listen to this podcast because he'd be very very happy. He got such a hard time 35 years ago when he introduced
Yeah.
this concept, right?
Yeah.
So great. So 0 to 6, assess the tongue, release if need be, use the tongue as
Yep.
your expander, supplement it with a nighttime oral screen. Great. Okay.
That's
All
it.
right. So
Yeah.
then maybe now, that what the American Orthodontic Association is big on at least advocating, and that
Hmm.
is child's first assessment at 7, right? So we're talking before 7, but let's just talk about, you know, parents remember, I don't know, in your country, do you have a convenience store called 7-Eleven? Do you have something like
Yes.
that? Yeah,
Yes,
okay.
we do.
So
Yeah.
they're big in Australia. So I like talking to parents about 0 to 6 and 7-Eleven. And they love 7-Eleven because they remember that. Can you tell
Right.
me now that same
Yeah.
kid who has the tongue tie, but it's only picked up between 7 and 11? What's your
Right.
protocol? Yeah,
Right. So 7 to 11 is very much dependent on how much how much narrowing we have. So say like I measure between the molars, the first year molars, and my goal is that there's 40 millimeters there. 40 millimeters or more, that's kind of the happy place. But I'm looking at the palate being, is it narrow, is it round, or is it wide, right?
yeah,
So there's of course the whole assessment of the mouth in terms of like the dental side, right? How are their teeth
yeah,
coming together? Is there a cross bite? Is there an anterior open bite, in terms of the space between the front teeth and the back teeth touching, all those aspects. But then I'm also looking at the child from a signs and symptoms perspective. So relating to their breathing, their sleeping, their quality of life, their mental health, all those aspects. And so if I assess a tongue tie, and in that age group, it's my treatment recommendations are not as black and white because
yeah,
if
yeah,
there is a little bit of narrowing or like a rounded palate, I still will often go the view of tongue tie release, myofunctional appliances with myofunctional therapy.
yeah,
Works beautifully.
yeah,
But if the child has what we call, it's a terrible term, but we say mutilated occlusion, right? Like the ones that there's a lot of problems dentally that are going wrong,
yeah,
and those ones, it's like you have the options, it's the fork in the road. It's either see an orthodontist,
yeah,
to which phase one, collaborative treatment is often the mode where palatal expansion before tongue tie release, because the thing with doing a complete tongue tie release is once it's completely released, the tongue wants to fully suction up against the palate. So you
yeah,
can't have an expander, a cemented appliance in there. It's going to negate all the improvements from the tongue tie release. So when I collaborate with orthodontists in that regard, we time it so that the palatal expander's in, and I've had a couple orthodontists that have allowed me to have it in for the active phase and
yeah,
not have it in for the whole long retention phase
yeah,
because
yeah,
they know and they trust that my tongue tie is going to be released and that full tongue is going to be suctioned up and it's going to retain the results. And then
great.
often we pop in a myo brace if there's any nerves around it to
Yeah,
to help maintain that.
got
So
it.
that's the one path. But the other path is I do the tongue tie release first and paired with a myo brace, and we reevaluate and we see where we are.
Mm,
And and then depending on the needs of the parent. And why I do that fork in the road, and I give the parents the options, we discuss all the ins and outs, is because the child that often goes the second route instead of going the ortho route first, those are the ones of the kids that are habitually mouth breathing. They have never had quality sleep in their entire life. Their tongue is
Yeah.
restricted, it's down. They often have speech challenges, not always, but can. They often have eating challenges, swallowing challenges. Their quality of life from a little person is not okay. And
Mhm.
I know, regardless of the shape of that palate, whether it's a super narrow palate with a high arch, whether it's a wide palate, when I do a complete tongue tie release, the whole tongue is going to be suctioned up. And that's the
Yeah.
beautiful part of it, is that I'm still going to get the same improvements. The improvements don't change in my practice on the shape of the palate. So
Mhm.
when I release that tongue tie completely, I see them 8 days later, regardless of how the palate shape was or how tongue-tied the tongue was, now that it's fully suctioned up, they are now with the tongue suctioned up, you can't mouth breathe. It closes the circuit. So
Yeah.
now it's like an on switch, and Dr. Zaghi says the same thing. When the tongue's suctioned up, it opens up the nasal airway. It
Mhm.
allows the child to instantly become a nasal breather. So we have
Yeah.
like a 90% conversion overnight from a habitual mouth breather to a nasal breather. And
Mhm.
then when the
Mhm.
tongue is suctioned up, it turns on the parasympathetic resting calm nervous system. So
Right.
then you have
Right.
this calming effect, which is also complemented by nose breathing. But the
Yeah.
biggest thing, and that you're a big supporter and advocate of, is quality sleep. With the
Yeah.
tongue suctioned up, it maintains and protects the airway. The tongue's no longer falling back when it's relaxing and compromising the airway.
Yeah.
So
Yeah.
now this child's getting quality sleep and it's happening instantly. They're going home the day of
Yes.
surgery and they're no longer thrashing. They're no longer having nightmares, night terrors, no longer bedwetting, all these arousals that the body was
Yeah.
doing
Yeah.
because their airway was compromised. And the parents want that for their child more than anything. And they want it as fast as possible, right?
Yeah.
These are the people that they love more than anything in the world, and they
Yeah.
want them to be feeling their best. And
Got it.
so I find it's a very mixed. I find more of my families that come to see me want the latter route. They say, like,
Mhm.
please, let's do it. Let's see how my child's going to be. Let's do the myofunctional appliances, the myofunctional therapy, and then if they need orthodontic care, let's go there. And often I find once they do my protocol, they don't need palatal expander anymore because they're no longer as narrow. They still could
Right.
benefit from, fixed braces or some other modalities.
Yeah.
So I find I call it interventional orthodontics, what I do, because what
Yeah.
I do tends to reduce the need or reduce the duration of treatment of traditional orthodontic care
Yeah.
down the road.
And you're talking about that long period of time that orthodontists leave the expander in. Since I've switched to doing much lighter force expansion, I
Yeah,
find bone is created as I open up the palate, so I don't have to leave that in for 6 months like I used to, right?
that's
Uh,
amazing.
uh,
Yeah.
yeah, when I trained in orthodontics, we only did rapid expansion, and we only did it for crossbite. The bad old
Yeah.
days of ortho. Now
Right.
I just look at the kids breathing. In fact. You said a great thing about some people being worried about scope of practice to be able to diagnose a tongue tie. I have the same headache when I lecture to dentists about diagnosis of sleep disordered breathing. They go, "Oh my God,
Oh my gosh.
that's not our."
Ah,
And I say, "Well, okay, so let's not diagnose it. Fair enough. You're not a medical practitioner. You're not a sleep specialist. But would it kill you to screen every kid in your practice?
yeah.
How much does it take you to print out a pediatric sleep questionnaire for every parent and just fill that
Yeah.
out?
That's
And
right.
if out of those 22 questions, seven get ticked yes, eight tick, then you've identified a problem, and
That's
the
right.
parent can then and it's just because they're just so worried about, oh my God, but if I sell a kid they have pediatric sleep disorder breathing, I'm not a medical specialist, can I do that? And saying you are helping this child, and
Yeah.
who cares if every tooth in the mouth is fissure sealed and the kid's got, great oral hygiene if the kid is not sleeping well, right? I mean,
Hmm.
that's why I think, every year for Dental Health Week in Australia, we say the same boring thing that parents are sick of hearing. Floss
Yeah.
regularly, brush
Oh
three
my gosh.
times a day, plaque
Yeah.
disclosed. And then I say, how about something new for Dental Health Week? And that is more decay is caused by mouth breathing than
Mouth
sugar.
breathing.
Right, yeah. So how about our focus really should be identification of mouth breathing, and that leads me onto the question, and that is, you've got great checklists on your website. How can
Yeah,
a parent assess if their kids are mouth breathing? Because you've done the research, and I've seen, I
that's right.
think what 55% of your pediatric population, what were mouth breathers from
Yep.
your, yeah, yeah,
Yep, that's for the
which
children and
for
for
children, yeah,
the infants. It's a so infants, so 12 months of age and under,
yeah,
the teeniest of the people is
yeah,
the biggest observation period is when they're sleeping.
when they're
So
sleeping. Okay,
when a baby is sleeping, their mouth should be closed and their
right,
tongue should be naturally sectioned up. And we
yeah,
can again share videos with you to share it
yeah.
in this podcast. You can lower the jaw down and you can visually see the entire tongue is sectioned up in that baby. But if
Uh-huh.
the mouth is open, often the tongue is therefore down as well.
Right.
So it's in babies. Let me just show. Here we go. My baby data. Yeah, 54% of my babies, and I've seen over 3,400 babies. So 3,400 babies. 54% of those babies presented with their
Yeah.
mouth open.
Right.
11% gasping, stopping breathing, and
Yeah.
21% snoring.
Right. Right.
And that's where a lot of families think babies snoring is cute. That's not
Uh,
cute.
no.
That is not healthy. That's not
Yeah.
healthy. And I would say baby photographers would be wonderful advocates to have this information
Yeah.
because if
Yes.
they see
Yeah.
these beautiful baby photos and the
Yeah.
baby is got their mouth hanging wide open,
Yeah.
that's a problem that they could
Yeah.
then provide checklists or provide information.
Yeah. And
So I find,
that
sorry.
photographer will never give the parent the mouth breathing photo because it doesn't look good, right?
Yeah, yeah, yeah.
Yeah.
And so I find in the science sim checklist, there's things to look in when they're awake. So, throughout the day, now babies will go through the awake phase where they're babbling, they're looking around, and babies and children, when little people, just like, putting mascara on or whatnot, when you look up, when your eye gaze is up,
Yeah.
gravity wins and your mouth is
Yeah.
going to open, tongue down. So what
Yeah.
I usually encourage families to do is when their child gets older, they're playing around with them, is play with them at eye level so that they
Hmm.
can help their mouth
Oh,
closure.
yeah. Great. Great.
And muscle memory takes 30 days, so at least minimum 30 days. So when a baby, for instance, has their mouth open, their tongue tied, we take care of their tongue release. We tell the parents because there's only one muscle that we know, their orbicularis that goes around the mouth. It's a lazy muscle, and sometimes it
Hmm.
just needs that training. So anytime
Hmm.
someone's holding that baby when they're asleep, when they're daytime naps or overnight, or awake and playing, is like play little games, close the mouth. But the big things, the big two-ticket things, if every parent can know for newborns, is number one is head position. So if that baby, his head is beyond 90 degrees, like the people we see falling asleep on airplanes,
Yeah.
gravity's going to win. Their mouth's going to open. So the
Yeah.
first thing is please correct the head position. Get it 90 degrees or a little bit
Right.
more forward, and 90% of the time the mouth closes. If it's
Okay.
still open, then that's when we press just on the soft spot underneath our chins, and that's
Yeah.
the floor of the tongue, which literally tongue will then elevate up in suction, and then often the mouth is closed. So if we
Hmm.
can just do those reminders as much as possible for newborns to train that muscle memory, oh, mouth closed, nose breathing, perfect.
Right.
For
Right.
children, assessing for parents to assess is you can assess them throughout the daytime. So,
Mm.
when kids are watching TV, when kids are reading books, doing homework, whatever it might be, those quiet tasks, their mouths should be closed and they should be nose breathing. Do
Hmm.
we expect to see kids mouth breathing when they're doing, exercise or really exerting themselves? Of course, they're going to push
Yeah.
themselves to their limits. They're going to mouth breathe. Same thing, children when they're at that, I call them puppy stage, when little people between, 6 months old and 2.5 years old get excited.
Yeah.
They start,
Yeah. Yeah.
So I tell parents, like, don't expect your child to nasal breathe 100% of the time when they're awake.
Yeah.
That is
Yeah.
not what we're looking for. But we
Right.
do want them as close to 100% of the time with their mouth closed, nose breathing when they're sleeping.
Yeah. Yeah.
So I think the biggest thing for parents to do is peek in on their child sleeping,
Okay.
and get that information over time because we want that mouth closed. There should be no snoring. There
Yeah.
should certainly be no gasping for air. That child should be able to peacefully sleep. And if they're not, then that's worth, an assessment, and so forth.
And maybe can we touch on the downside of mouth breathing? I mean, in other words, we're
Yeah,
talking about early assessment and intervention, and that's totally on board with that. What
right.
can happen, say, when tongue restrictions are missed or mouth breathing is missed? Maybe we can two separate questions.
Yeah, well, they kind of come together. So,
Yeah,
in speaking about the breathing part, so we know if there is, like, the ideal anatomy is no tongue tie. So, tongue is suctioned up against the roof of the mouth. With that, the child of any or human of any age, baby to adult, should be nasal breathing, right? The benefits of nasal breathing, just to rhyme off a couple, the nose literally made for our breathing. So, it slows the airflow, it cleans it, it filters it, it moistens it. And the best part about it, slowing it, and it incorporates nitric oxide, which comes from our sinuses. And
yeah,
that's a dilator, opens things up, right? So it allows the air that we breathe to then go from our nose, and then it's clean and pure, and then it goes to our lungs, and it goes to our lowest lobes of our lungs because of that
yeah,
nitric oxide ability. And so we get more oxygen delivery. We get double, two times the amount of oxygen delivery thanks to the slowing of the airflow and the
mhm,
nitric oxide that gets incorporated.
yeah,
Wonderful.
mhm,
But if we are tongue-tied, or we're just, for whatever reason, habits, pacifiers, thumb sucking, whatever, we are mouth breathing, and we're mouth breathing habitually, we don't get that filtration. So the air is going to go in, and the tonsils and adenoids, they're back there.
yeah,
They're now having to do a ton of work because
yeah,
the air is not being filtered and slowed and all those things that the nose does. So that's where we often get enlargement of the tonsils and adenoids because they're overworked. And then when they get enlarged, they get inflamed, and then they further compromise the ability for that person to nasal breathe, which then
yeah,
makes them mouth breathe more. So we're
right,
not getting the appropriate filtration. Then the air that we're getting, we're not getting any nitric oxide. So the air is only going in the upper lobes of our lungs, and we're referred to as chest breathers.
yeah,
And when we're chest breathing, we're then having to take double the amount of breaths to match what a nasal breath would be. So we're having to do way more work. So more work on our cardiovascular system means our heart's working more, our lungs are working more, our bodies are having to work more. So there's more research coming out nowadays that with habitual mouth breathing, it's higher incidence of cardiovascular events, like including stroke and heart attacks. So I would say anyone that you love in your life, tell them to shut their mouth
yeah,
and breathe through their nose, right?
yeah, yeah,
Um, so those are some of the aspects. The other big part is nervous system. So
yeah,
the nervous system stimulation, when you breathe in and most importantly, breathe out through your nose,
yeah,
it triggers the rest and calm parasympathetic nervous system, which
mhm,
is what we want to be in for, as much time of our day as possible. But when we breathe in and out through our mouths, it triggers the sympathetic fight and flight nervous system. And
right,
so that's where, when you mentioned the incidence of Ritalin prescription in Australia. Well, if you are looking around and this kid's bouncing off the walls, but they're regularly mouth breathing when they're awake, they
yeah,
for sure are going to be mouth breathing, mouth open when they're sleeping, meaning they're not getting quality sleep.
right,
Um, Under age 12, children have a paradoxical reaction. Instead of them moping around, I'm so tired, I need a coffee, I need a nap.
yeah, yeah,
It's paradoxical and they're hyper. They try to fight that feeling of sleep. And
yeah,
so that's where we're seeing across the whole world an overdiagnosis, misdiagnosis of ADHD or ADD,
yeah,
when these kids are just chronically overtired. But they just
right,
don't know how to act. They don't know how to turn it off. And
yeah,
so they fight it. And it's, these are the kids that are being labeled behavior kids or problem kids when it's not them. And I just tell them, it's not you. It's well, my patient base, often it's their tongue tie. And we take
yeah,
care of that tongue tie completely. We get them nose breathing. We get that nervous system calm. We get them quality sleep. And you literally see them in 8 days, and it is an entirely different human. And that's what
yeah,
the parents will say. Like this child, like my kid never woke up in the morning happy. They were always
yeah,
moody. They're always grumpy. It was like the day was a challenge. They were hitting kids at school. They had no emotional regulation. All these things, um, gone. And we're talking within 8 days. Because I see
and
my patients a week later. That's why I say 8 days.
right,
Um,
right.
yeah.
Well, and then that brings me to the question of large tonsils and adenoids, right? Um,
Yeah.
they're large for a reason. And
Yes.
I've had so many kids that obviously, so I used to do in-nose and throat route first. And of course, in Australia, most in-nose and throats will see 80% blockage, bang, removal. But then
Right.
these kids continue to mouth breathe. So it's not as
Of
though
course.
taking out those T's and A's makes them a nasal breather. And what
That's
happens?
right.
You get regrowth because exactly what you described. The adenoids and tonsils are like the filter in your aircon. And if that's not, if you've still got that dusty air coming in, that filter needs to be continually clean, right? So
That's right.
changing the kid from a habitual mouth breather to a nasal breather, I see huge changes in adenoids and tonsils. And I also nowadays advocate the whole check the gut, what's the vitamin K
Yeah.
situation, vitamin D. So I look at alternatives, and if I then see no change, then sure,
Mm-hmm.
right? So I guess it's the chicken egg scenario, isn't it? Large
Mm-hmm.
asthma tonsils can cause mouth breathing, right?
Mm-hmm.
Um, but what about mouth breathing causing the large adenoids and tonsils? Looking at the other way around.
Yes.
And
And,
and, and,
and
and sorry, yeah,
yeah, yeah. And I think tonsillitis is a fascinating topic right now, more than anything,
right,
because we're in the post-COVID world, right?
yes,
So
yes,
pr pr what's supposed to happen? You need the tonsils adenoids that for, filtration, immune system, the first 2 years of life. First two
yeah,
years of life, the immune system is not as developed, it's underdeveloped, to which we need them, ideally. If we
yeah,
can have them to do their functions, we want to keep them.
yeah,
But after age 2, they are supposed to naturally get smaller and smaller and smaller, regress. And by age 8, you should not visibly see tonsils when you look back in the back of someone's
yeah,
mouth.
yeah,
Throughout their lifetime, when they get sick, they will puff up because they're, using, and then when they're healthy, they go away. It's kind of like a jack in the box,
yeah,
go away.
yeah, yeah, yeah,
But what we're seeing, and I've worked with various ENTs in Canada, anyways, is that post-COVID, the kids that had COVID from a young age, they had, so under age 4, had COVID, had RSV, had croup, so the respiratory sicknesses. What
yeah.
we're seeing is that the viruses have somewhat mutated in a way that the adenoids and tonsils don't seem to be regressing as they once were. So
Okay.
we're seeing kids that, they look relatively healthy, they meeting all their checkpoints, all this stuff, but what the heck, they're mouth breathing. Like their mouth is
Mhm.
open when they're sleeping. But their tongue function's great, their growth and development's great, but this is what we're starting to see. And when we get X-ray of the adenoids, oh my goodness, we're seeing like severely enlarged adenoids, 2 millimeter
Yeah,
airways.
yeah,
To which like, well, what the heck? Like, for when they're that big, there's only one answer, and that's we need to remove them to have this child
yeah,
be able to nasal breathe. So in those cases, I see a great benefit of having them removed. But as you mentioned, just because they're removed, the child's not going to instantaneously use their nose for nose
yeah,
breathing.
yeah,
That's where we have to ensure a couple things are also in check. That one, there is no tongue restriction because we know if there is, that tongue is going to be anchored down and it's going to contribute to them mouth open, mouth breathing. Whereas we want that tongue suctioned up, sealing that so that it supports the nasal breathing circuit. Um, but then on top of that, that's where myofunctional therapy, myofunctional appliances fit in beautifully. And I wish that every ENT worked with a myofunctional therapist
oh yeah, yeah.
because their
Amen.
long-term results of the neuromuscular imprinting of the optimal habits of mouth closed, nose breathing,
Yeah,
like they would have such lower instances of relapse or
yeah,
resurgence, right?
yes, yes,
But those days haven't really seemed to come to fruition yet.
right.
I have hope for our our humankind, and hopefully
Yeah,
we can get
yeah,
that collaboration moving forward. Because at the end of
yeah,
the day, I truly believe that every healthcare provider, like we want our patients to be their healthiest, to be their happiest, and we can have that, we can achieve that when we work together and we share our knowledge, and we treat every patient as if they're our own child.
absolutely.
Yeah.
And then, for mothers who are listening, the one thing that they're going to ask, well, what could they possibly do to prevent airway issues in their children from birth. I mean, unfortunately, TikTok trends make it too simple. They say, well, if your kid's mouth breathing at night, mouth tape them, bang, there's your
Mm,
solution. So could you touch on that from a mother's perspective? They've identified
yeah.
that their child is mouth breathing. What would be the next step?
And what age are we in this
Maybe
situation?
maybe again go 0 to 6.
0 to 6. Okay, so it's for my first thing would be if the child is mouth open, mouth
Yeah,
breathing, and they're not like without a reason. So it's
yeah,
not they're sick right now. It's not that they're going through teething. It's not that they have growing pains because we know when the body is in a state of discomfort, so such as
yeah,
teething, growing pains, sickness, the emergency vessel, which is the mouth, is going to open. They're going to be more likely to mouth breathe, right? So
yeah,
outside
yeah.
of those scenarios, if they are regularly mouth open, mouth breathing, especially when sleeping, I
Mhm.
would urge them to do their own. Can the tongue separate from the floor of the mouth? Like my first and foremost line is that we know that the tongue is just such a culprit of that, that if it's restricted, that child of any age is going to be in a compensated function. So can we go underneath the tongue? Can we separate it from the from the floor of the mouth to then be able to fully suction? Because what I see in my patients, you see my babies, instantly, as soon as I release the tongue, we have videos. I literally release the tongue to have an infant. We're taking a video and you see, watch the tongue and it fully suctions up. It does it right away. And so
Right.
you get them nasal breathing right away without having
Yeah,
to go through training or appliances or anything. Is
yeah,
so if we can see a tongue restriction as pathology, and if we
yeah,
call it pathology, we treat it, right? So if it's
yeah.
pathology, we release it completely. We then reevaluate. And 90% of the time, they're not mouth breathing anymore. So that's where I
Okay.
think that should really be at the forefront.
Yeah.
I'm not a big, if there is a tongue tie, I do not want someone taping a mouth closed. I don't, because the tongue is truly obstructing the airway as it relaxes and in deep qualities, in deep sleep. And, it's not helping them in that regard because their sleep challenges are not from their mouth apart. It's because their tongue is down and it's relaxing and it's compromising their airway. Now, as they're getting older, so closer to like the 2.5, 3-year-old age group, that's where, even with the tongue tie, so MRC, Dr. Chris Farrell, their appliances and various other, there's so many appliances out there, but I regularly use MyoBrace. Even with a tongue tie, the way that the appliance is built, that has that portion on the bottom that lifts the tongue and engages it and holds it in an upward forward motion. So we have kids on new patient exams that before I release their tongue tie, they get a Myer brace, and the parents regularly report there's been improvements in their sleep
Right. Right.
with wearing it. But of course, you also have the kids that they haven't had any good sleep. They're tongue restricted. Their behavioral things are battles. Those kids, are they going to be wearing a removable appliance? No.
Yeah. Yeah.
So that's where, it really is individually dependent. Um,
What's interesting when I issue a parent a my brace after we've done, the airway checks and tongue toe release, etc., and the parent says, "Oh, they keep spitting it out at night," and then I say, "Well, that's telling you they really need it. They really need
yes,
that appliance
that's
because that's a
right.
way of you knowing that they're not breathing through their nose." So
Yeah.
I turn it around because they say, "Oh, look, this is an impossible thing, Dr. Mahoney. My kid, we give it to him." He falls asleep. No sooner do we come back an hour later, it's out of the mouth. And I said, well,
Right.
that's telling you that we've got to change. And then, we introduce oral myology, and then they've got to go back
Yes.
and, you know what parents are like. I
Yeah.
mean, they try to do the best
Yeah.
for their kids, but they also would like it just simple. It's
Yes.
kind of like, can we just do one thing? And I say, well,
Yeah.
not really. I mean, this is the thing. But then when they see the change in habit of that kid and their malbrace is now staying in all night, wow, they
Yeah. Yeah.
really they're firm believers. Yeah.
Yeah, and I think the big thing with parents is expectations, right? So
Mhm.
like when the child gets a Meyer brace, we tell them right off the hopper that it's going to come out. It's going to fall out. It often takes, I find, 3 months because you're training subconscious neuromuscular
Yeah.
behaviors and imprinting. And so, that 1 hour of daytime aware is very important because you're actually actively engaging it. you're closing your mouth. So you look like a monkey because you're pulling all those muscles, you're
Yeah.
strengthening them. And that
Yeah.
active wear then transitions to the nighttime wear when you shouldn't see the mouth brace. The lips should be fully
Yeah.
closed around it.
Yes.
So, but when you first start, you're gonna see the mouth brace. The lips are gonna be
Yeah.
apart, and that tells
Yeah.
you why we're wearing it. And it's kind
Yeah.
of like acts like the cheerleader to tell you need to wear it in the daytime.
Yeah.
Daytime,
Yeah.
daytime, daytime, daytime. Get that active wear. And then as you go through the nighttime, that, 1 month, 2 month, 3 months, Eureka! Oh my gosh, it
Right.
works. Their lips
Right.
are closed. It's staying in all night,
Yeah.
and so forth. Now, a cool little piece of data. So, of my patients that are Myo brace wearers, when I release their tongue ties, 88% of them, and that's at a sample of 420 patients,
Right.
88% say that the Myo brace is way more comfortable afterwards. And
I
that's
see.
because
Right.
the appliance isn't doing all the work keeping the tongue up. Now the tongue is just naturally suctioned up, and the
Yeah.
appliance is then, acting
Got
as
it.
a supportive adjunct.
Yeah.
Um,
Yeah.
so which is kind of cool too, that relaxation of facial tensions.
And I have a lot of teachers who listen to this podcast. I would say the category child educator, wherever that may
Yeah.
entail. What's some informational resources that they can use to maybe raise airway concerns with parents?
Right. So that's where what would be fantastic is, and not that I'm trying to have people go to my website, but our
Yeah.
self-assessment checklists on our website are incredibly accurate. Like
Good.
if you're answering yes to multiple of those check boxes, to which
Yeah.
many of those teachers would observe in their classrooms,
Yeah.
it is indicative of airway compromise, and most often in my world, a tongue restriction. Tongue
Okay.
restriction, or it could be myofunctional disorder. So they in need of myofunctional therapy or appliances can assist too. Also, like airway ortho, as you're doing. But
Yeah.
so even taking a few of those, but the biggest things from a teacher's perspective would be if the child is especially the ones that are having challenges in the class.
Yeah.
How are they breathing? Just watch them in the day, one day, assuming
Yeah.
they're not sick.
Yeah.
How are they breathing? And often they are mouth breathing. And then if they're
Right.
mouth breathing, they I usually call it the perfect storm, right? So they're mouth breathing. So they're having sympathetic overload because they're mouth breathing. That means their fight and flight nerve system is off the charts. So they're already in a dysregulated state.
Yep. Yeah.
We know they're not having good quality sleep, so they don't have much capacity. And then on top of that, if they're tongue restricted, a lot of them do have challenges either with eating or
Mhm.
with speaking or both. So problems with eating. So are they eating, fruits and vegetables and meats and, a balanced diet? Often not, because it's really hard to chew and properly
Yeah.
swallow,
Yeah.
especially if there's a tongue restriction. So they're going to have more of the processed foods that are often sugar boost, sugar crash.
Yeah. Yeah.
And then if they also have speech challenges, and they aren't able to either get the words out, so I say their brains are working faster than their mouths can keep up with,
Yeah.
or they have true speech challenges where they are unable to articulate. That is incredibly frustrating for any human being, especially a little person that doesn't
Mhm.
have a developed, prefrontal cortex, and they're going to have outbursts. So rather than us being like, oh, this child is just, a terror, be like, oh my gosh, like I don't see that. I see a child that's actually trapped in their body and they're suffering. And
Yeah.
they need us more than anybody. And I've seen it over 4,000 times. These children change. And then the kids that are not the problem children in the class, that a lot of them also are suffering, but in a different way because they've compensated differently.
Got it.
So they're giving all of their energy to be perfect and perform and do all the things the teacher wants. But they might also be mouth breathing. They might also have these big, big dark circles underneath their
Yeah.
eyes and whatnot. And then what happens is those kids go home, and what happens with their family? All those things, right? The outbursts, the upsets, the not wanting to eat their dinner, and so forth. So I think as a whole, we need to look at children, from a parent perspective at our homes and a school perspective. And I
Yeah.
think simply it starts with how are they breathing? How are they sleeping?
Mm-hmm.
Let's flip up their tongues.
And for those people listening to this purely as an audio, please remember that we do also convert much of this footage into YouTube. So Michelle, who is my coordinator for these podcasts, will be happy to share that information. And obviously, at the end of this podcast, we will put up your website details and how they could contact you, Sigal. That's great.
Yeah,
Um, so so if I was to say to you, and maybe we started this interview, is what is a standardized assessment protocol for airway? Could you just touch base on that? Like Zagi has his six flags, right?
right.
What would you say? What would you use?
Right. Well, that's a great question. So I would say that it does vary based on age group.
Yeah,
So if it's an infant versus a child, teen and adults would be pretty similar.
yeah,
But for my evaluation of a patient, so I'm gonna let's talk, children, teens, adults, that age group. Um, my signs and symptoms are quite comprehensive, which most of them would be on my checklist on my website, which include their daytime behaviors. So I ask and want to know everything. So I'm very comprehensive.
yeah,
So
yeah.
beyond like the fast, six things is looking at like their breathing. So their observations at home in terms of the daytime. We look at them here. So all my patients, we observe them within their appointments of how they are. We look at their body in terms of posture, in terms
Yeah,
of, all the things that are related in my tongue tie world. So forward head posture, rounded shoulders, limited neck range of motion are all things very common,
yeah,
commonly seen as body compensation. So we do a whole workup of the older people of all the range of motions, to which neck extension is usually the worst one.
right.
Very few people with a tongue restriction can extend their neck properly. So a lot of them are going to have degrees of tension in the neck, upper back, and so forth. Um, with that, many have headaches and migraines that come with it as well. Of course, I look at the profile, from the side. I look at their Mallampati score, so their airway when they open up. I visualize their tonsils, and that gives us a pretty, at least an idea of what their adenoids might be. Because if tonsils are really big and angry, adenoids
Yeah,
are often double or triple what we see in the tonsils.
right,
That's
right.
usually the relationship. I look at their occlusion, so the dental aspect of how their teeth are coming together and aspects of that. And then of course the tongue has to be assessed in
Okay,
terms of
yeah,
its separation. That to me is a non-negotiable.
yes,
Looking at, there you can see how the person's swallowing. Is it a tongue thrust, which is more common when a restriction's place, or is their tongue able to maintain contact with the roof of the mouth while they swallow? So I look at the tongue. I look at the upper lip tie as well. So those are the two ties that I assess regularly and release regularly.
you gave us a good assessment off the tongue. What do you look for on the lip?
Yeah. So the lip, I do what I call like the modified Kotlow. So for Kotlow, I look at his is very much based on where it is visibly attaching. So we know the upper lip frenum, normal anatomy, should attach at the color change, the mucogingival junction.
Yep, yep,
If it attaches lower than that, kind of in between the color change and end of gum pad, then it's a class 2 lip tie. If it attaches at the end of the gum pad, it's a class 3. And then if it wraps onto the roof of the mouth, class 4.
yep.
So I do look at that in terms of technically where is it attaching,
Yeah.
but then I
And
look
sorry,
at the
could
function.
I just add one thing? Because would the same, because when Kotlow published that original data, he
Yeah,
didn't mention buccal ties. Would you say
right.
buccal ties a similar assessment or different can of fish?
Different can of fish.
Okay. Okay. Sorry.
Yeah.
Keep going.
Yeah, yeah.
It just triggered me. Yeah.
No, no, totally. And I
Yeah.
can once I finish the lip bit,
Please,
I'm
that'd be
happy
good.
to share my experience with the buckles too.
Thank you.
So
Thank you.
with the lip, I look at so technically where is it attaching, but then I look at function. And function to me is the most important. So the
Yeah.
lip should be able to easily flange upwards, covering as close to 100% of the nostrils with
Yeah.
very little tension or discomfort. So it should
Mhm.
have that natural ease of range of motion. But
Yeah.
then the biggest thing, especially for releasing a child, teen, or adult, is is the lip tie so tight and restrictive that it's truly puckering the lip upwards, that
Hmm.
is holding the lip upwards, preventing the ease of effortless lip closure.
Okay.
So
Okay.
I truly have patients that cannot physically close their mouths because their lip tie is so tight, it's keeping their lip held up, and then their
Okay.
tongue tie is putting their tongue down, so that child is mouth open 24/7.
And
I
would
have
that
patients.
child probably have more of a gummy smile, would you say, as a guide, or not so?
Uh, They can.
Yeah.
So gummy smile I find is very much related to the more narrow the palate. So the more narrow the palate, then we have more gummy show
Yeah.
versus when we get expansion, I'm sure you see this,
Yeah.
then you alleviate that gummy smile more than
Okay.
anything. So I find gummy smiles aren't as much related to the lip ties as they are related to the shape of the palate, so the growth and
Yeah.
development of the maxilla and face.
Yeah.
So I put those aspects of the lip together. And for babies, of course, the flange is one of the main factors of being able for that baby to deeply latch for breastfeeding.
Yeah.
So that's also a factor in place. And the last factor is the excess diastema, so spacing between the front central teeth. Now, what
Okay.
most people don't realize, especially families, is ideal spacing is 1 to 3 millimeters between baby teeth. So when a child has 1 to 3 millimeters between those teeth, which can
Yeah.
look to a lay person's eye, it can look big,
Yeah.
but that's
Yeah.
good. That's good
Yeah.
growth and development
Yeah.
because adult
You,
teeth,
you,
as we know, they're bigger.
you know,
They
if
take
I
up that space.
right, if I ever went back and reopened my practice, so I went back 40 years, I'd
Yeah.
probably use the term no gaps orthodontics. Do you know what I mean?
Yeah.
Because I would focus on what you just said. Because
Yeah.
honestly, parents think, oh, my kid, this I hear all the time. When I get a 7-year-old that starts seeing the crowding, no room for the canines, that parents always say, but when he was a toddler, he had the most beautifully straight
Beautiful
teeth,
smile.
right? And then I say, but
Yep.
that's the problem. That's a sign that
That's
he
the
had
problem.
crowding. And then I just
That's
say,
it.
well, look at the size of his baby teeth and his adult teeth. Can you see the difference there? And then the light
Yes.
bulb goes off, right? And then the
Yeah.
parent goes back and tells their sister and looks in their niece or nephew's mouth. Oh my God, you need to go now because
Yes.
there's no gaps, right? So,
That's right.
and I think I don't know about Canadian dental schools, but Australian dental schools, they do not have one photo, one lecture of what a pediatric, as in before school type dentition should look like. Do you know what I mean?
Right. Yeah. Well, we
Uh,
have them, but they are
yeah,
incorrect. And so I
right.
mentioned it in my lecture I gave at the, because I've been following patients. So I've been, at my clinic here has been 9 years. So I
Yeah,
followed patients for 9 years and
yeah,
I follow their eruption. And these are the children that I released their tongue ties as babies. They did not
yeah,
have pacifiers or any habits or anything to, interfere with the tongue placement. And their eruption of their primary dentition, there is 1 to 3 millimeters between every single tooth.
yeah. Wow, good to
Every
know.
single
Yeah,
tooth, molar
yeah,
to
yeah,
molar. And
yeah.
it's a beautiful thing. The only time that you then see the closure of the primary molars
Mhm.
is around the timing of when the 6-year-old molars are starting to come in. Like they haven't come in yet.
Yeah,
Their eruptive path has begun, and that's
yeah,
when we see closure of the space between the first and second primary molars.
right.
And then the 6-year-old molars come in beautifully. And then, of course, as we have the exfoliation or the loss of the baby molars, we have the leeway space, right? So
Yeah,
then
yeah, yeah,
everything just, oh my gosh. So
yes,
like,
yeah,
so really, if we do preventive, proactive care as an infant, what I see is we don't need any flossing. You shouldn't have to
yeah,
floss your kids' teeth because there shouldn't be any contacts really
yes,
until just before age 6 when those back molars close.
yeah, yeah.
Um, and I say in my lecture, this was not taught to me in my
Oh,
training,
yeah,
but
yeah,
this is
yeah.
what we see, and this is truly what optimal growth and development is. And the
Mm,
jaws are wide and broad
yeah,
or arches and
yeah.
ease of nasal breathing. Like it's a beautiful pathway.
I
Um,
think, when you look at Kevin Boyd's research and when he looks at
yeah.
anthropological studies of
Right.
skulls that had zero crowding, had room for their wisdom teeth, right? When do
Yes.
you see that? Maybe they had a lot of attrition. Why? Because they actually had to chew for a living. I think our
Yes.
problem in modern society, the kids don't chew for a living, right?
Mm-hmm.
And then you've got all these airway problems to add to
Yep.
the boot. So it kind of amazes me how any kid. I mean, I'm an orthodontist, and so I've got a skewed audience. I don't really get to see the average population. Every kid who's sent to me
Same.
is mouth breathing, no room for their adult teeth, right?
Right.
But having said that, when I talk to colleagues, when I talk to my pediatric colleagues, they're saying, look, this is an endemic. This is like every kid. Not we're not talking this.
Globally, around the
Yeah,
world.
yeah. This
Yes.
this discussion we're having today is not about that 1 in 100 kid, right? This is not
No.
like Prader-Willi syndromal kid. This is every
Correct.
kid that we see in Western society, right? And
Yes.
unfortunately, good thing for orthodontists, because if you're not preventive, you're going to get that kid with crooked teeth, and the parents are going to say, we want teeth straight. But guess
Yeah.
what? I was taught wait till 13, pull out 4 teeth. That's how you make the space. I now get it. You
Right.
make the space before those teeth come in, right? And that
Yes.
and that gives you that healthy kid. Whereas you can have an unhealthy kid who's on his ADHD medication with straight teeth thanks to braces. That, what's my saying?
Exactly.
I could, if I straighten your teeth, but I don't check your kid's airway and their overall sleep, it'd be like straightening the deck chairs on the Titanic. It's going to end badly,
Right.
right? Uh,
Yes.
so, uh, so it's, I'm so glad that you have all these tools that people can assess, because unfortunately, hate to say this, but my profession are not going to be the game changers. It's not the dentists or orthodontists who are going to, it's the mums. The mums have this
Yes.
sixth sense of what's best for their kids. You know that, right? Uh,
Yes. 100%.
uh, and they're the ones identifying, and thank God for social media, because social media portrays mouth breathing as really bad.
Hmm.
And that's how the message gets through to the parent, right? And the
Yes.
parent then looks for a provider who talks the talk, walks the walk, and says, "Yeah, I can help your kid, and I know why they need." But then you
That's
get other
right.
dentists who are going to say, "Oh, well, my kid mouth breathes too.
Yeah.
I don't think it's a problem." So it's
Yes.
yeah, yeah, and this is
Yeah.
the thing. Until we all agree, is as a consensus, what should be a healthy mouth, what should be
Yeah.
what you said, 1 to 3 millimeters between the primary teeth. If everyone just agreed on that, how good would it be that, because I don't see 4-year-olds like as a routine exam. General
Hmm.
dentists do. Now, for general dentists, even from when their lifelong patient falls pregnant, why don't they have a talk to their mum to be about airway and about what to expect when your
Yes.
baby's born and what to expect when
Exactly.
those, yeah, that's real
Yeah.
good education, right? But
Yes.
if that day will ever happen in our lifetime, I don't know.
I
But
know.
can I draw
Yes.
you back to the,
The
I
buckle
love this.
ties?
Yeah, but the parents here in Australia, they say buccal. Like it's
Buckle.
not correct, but I can't, like sometimes parents come in, they say,
Tomato, tomato.
yeah, they say,
Yeah.
does my child need bracelets? And I'm saying, well, I don't know. It depends on your fashion statement, but braces, I can help you with.
Yeah.
So in the same
Yeah.
way, there's a big thing, parents talking about buccal ties, right? So
Right.
I
And,
know what they're talking about, but tell
yeah.
me, how can I, as a clinician, or maybe, mums, how can they check buckle ties?
So in terms of these, and I would say these are definitely a topic of conversation right now. Like around the world, I feel like they're popping up everywhere. There's some people that are releasing them at the same time as tongue and lip ties, and then there's people that aren't. So in terms of my investigation of them, so we know that just like a lingual frenum and a lip frenum, buccal or buccal frenums, they are
Yeah,
normal anatomy, right? We know
yeah,
that.
yeah,
But
yeah,
when things are restrictive, that's when things are problematic. Now,
yeah,
in my experience, I have yet to release a buccal or buccal tie
yeah,
because what I find is once if a tongue tie and a lip tie is released and it's released completely, all the tension that was in these buccal ties are
yeah,
gone.
right.
So I've had patients where they're like, "Oh no, no, the upper right, the upper left, it's painful, it's problematic, it's doing all this
Yeah,
tension pulling." And I
yeah,
will
yeah,
tell the parent, "I will take pictures." And so I've got lots of I document
yeah.
everything here. I'm
Wow.
big on research. So I've
No,
taken
that'd be
pictures.
that'd be a great article. Yeah,
Yeah, I've taken pictures of these buccal freedoms
yeah,
and I take them before I do the tongue tie release and then after the tongue tie release. And
Yeah.
then if the upper lip tie is restrictive, it needs to be released because it's, very restrictive. It's holding the lip upwards. It's a source of tension. I release it. I take a picture of the buccal freedoms, and
Yeah. Yeah. Yeah.
any tension that was in them is
Yeah.
100% naturally resolved.
Wow. Good to know. Right.
And so in my mind, it's like, so, and again, everything to me is anatomy and physiology. So
Yeah.
I have yet, in my experience, to see a reason from an anatomical or physiological benefit to release them. Now, my big aspect, like what I'm hoping those providers that are doing them, because to my knowledge, I have yet to see a study or any kind of discussion about a provider only releasing the buccal frenums and
Yeah.
seeing what is the effect. So, like
Yes.
only release the buckles and see what happens.
Yeah.
But
Yeah.
all the research that I have seen, all the people that I've spoken to that have released them, they release it at the same time as the tongue and lip tie. And I would argue that the improvements are not from the buckles, they're from the tongue tie and the lip tie
Got it.
release.
Yeah. Yeah.
So that's what I see in my practice. And so for me, and my results are so consistent and reliable. So I'm having over 90% success in of all the improvements with my tongue and lip tie release. If the buccal frenums were as problematic as people are saying, I wouldn't have the success of improvements that I'm having, to which I would then be looking, is there something else that I can be doing? Is there more surgery that I can be doing?
Yeah.
But because across the board, I have such incredible improvements and results reported across all ages,
Yeah.
I I would love for the providers that are doing them to do like a crossover trial, like take a group and release the buckles and then have this group just tongue and lip and then see how they're and then oh the buckle group, would you like your because they're not going to have many improvements, I don't think. They might have a little bit of relaxation of the
Yeah.
face.
Yeah. Yeah.
But they're not going to have many improvements in other aspects. So then you're going to say, oh, can I release your tongue tie, lip tie too? And then
Yeah.
release it. And then you're going to see, holy eureka, all these improvements.
Yes.
That, in my mind is like, I don't want to do more surgery on a child if I don't think 110% it is going to be of benefit
Yeah.
and of good. And
Right.
so yeah, so when I lecture, I laugh and I show these cases of these buckles that
Yeah.
magic, that
Yes.
all the
Yeah.
tension is gone. And the
Yeah.
kid says, "Oh, this is so painful." It's not painful, and wearing the mire
Yeah.
brace afterwards is more comfortable. Well, yeah, that's because when you do a complete tongue tie release, the tongue comes up and forward, and it
Yeah.
naturally allows the facial muscles to relax and allows the mandible, the jaw to move down and forward. So
Right.
everything just relaxes and opens up of the face,
Yeah. Yeah.
to which alleviates the tension of those buccal frenums.
Right.
So,
Right.
anyways, that is what my experience is. I know there's differing opinions out there, but
Yeah.
hopefully there's, more clarity. And I do plan to publish. Right now, I'm
Yeah.
working on many different publications. This is my year of
Yeah.
publishing my past decade of research that
Great.
I've been building
Well,
and
I mean,
and doing.
talking to you, you have very sensible, practical solutions, which is what I never hear when I interview an academic, right? An academic who's not really treating patients. You
Right.
can tell their answers are all kind of, they'll quote this paper and that quote, and then you kind of, and you ask them a question like that, and it throws them because
Yeah.
there's no published research and they don't actually see patients still, right?
Yeah.
So yeah. Can
And
I
that's
tell?
why.
Would
Oh, sorry, go
would you
ahead.
ever so Kotler was big on, the labial frenum being attached in the wrong zone, right? So in the
Yes.
zone of attached gingiva. Do you ever see buccal highs sort of attaching not at the mucogingival junction, but sort of more gingival, or no?
Not often
No.
to be
Yeah, no, I don't. That's what I'm saying. Yeah,
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 and I
yeah,
find when again, if there's problematic restrictions of the tongue or the upper lip, once they're released,
yeah,
any visible tension pull that might be going beyond
yeah,
is gone.
yeah.
It totally alleviates instantly. Yeah.
Now, two questions, probably not related to what we were thinking, but why did you call your practice Little Bird? What's that about?
Yeah, so my last name's pronounced Siegel, like the bird,
Sigal.
like the
Yeah. Okay. Right.
and
Right.
my dad actually, Dr. Michael Siegel, he is a pediatric dentist,
Okay.
and he was kind of he's professor emeritus now from University of Toronto, but he was the kind of the big guy. He's you know created a clinic for folk with special needs, one of the largest in
Yeah.
the world, outside
Yeah.
a
Okay.
hospital, and he was head of
Yeah.
pediatrics, and he's a tall guy and very big shoes that he walked in as an academic and clinician
Yeah.
and
Right.
innovator.
Right.
And so he was coined the Big Bird because he would go around the hospital
Ah.
and he would have a yellow
Yeah.
surgical gown and he would
Yeah.
fly
Yeah.
around everywhere.
Yeah.
And so some of my late mentors,
Yeah.
Dr. Baker, was one of my beautiful late mentors, and he coined the term. He would refer to me as, "Hey, where's the little bird today?
Ah.
Is the
Nice.
little bird coming
Nice.
around?" So when I opened my practice, unfortunately he had passed just
Yeah.
before I had opened my practice,
Yeah.
and I thought, what a perfect. It's a kind of ode to him, one of my mentors, and it's an
Yeah.
ode to my dad because he's the big bird and I'm the little bird.
Yeah. Very nice.
And for me, it's all about taking care of people from birth, so before, even before they're
Yeah.
born,
Yeah.
prenatal care, to
Yeah.
till they're soaring. Like, let's just get
Right.
every human, wings spread far and wide, and
Yeah.
just being able
Great.
to
Great.
enjoy their life to
No,
the fullest.
yeah, I'm glad I answered that. That makes sense.
Yeah.
You know what got me started on this whole early treatment airway non-extraction? It was a lecture that I listened to with a guy called Donald Woodside, who I'm sure you would know from.
Yes.
He was head of ortho and part of. I always laugh because in Toronto, you have a hospital which is very famous. It's called the Hospital for Sick Children,
Sick
right?
children.
Yeah. And I always used to say, well, I wonder where the hospital for healthy kids is, because
Yeah.
it's kind of obvious. But anyway, in there was a guy called Donald Woodside, and he was collaborating on a research project with a guy in Sweden called Linda Aronson. And Linda
Mm,
Aronson was the big guy on adenoidal faces and the whole, if you don't fix the airway early, you're going to get more crowding, narrower jaws, longer faces. So this is, we're talking in the 70s, right? And
yes.
Donald Woodside was a big advocate of early treatment. And then I don't know what happened in Canada, because Canada was world renowned for this interceptive. And now, I'm like you, I have my board certification from the Royal College of Dentists in Canada for ortho, right? But let me tell
Yeah.
you, the standard of care for ortho in Canada is still very teenage-based, extraction-based, headgear-based.
Yes.
So I just,
Yes.
yeah, it's kind of
That's
it's kind of
unfortunate.
like, yeah, and yet these things have been around for a long, long time, right?
Yeah.
Um, well, thanks so much for giving up. I guess it's your Saturday night there, is that right?
That's right.
Yeah.
Yeah.
Right. Okay.
And your Sunday morning, I'm talking to the future right now. Yeah.
Yeah. I always say, I used to do a lot of lecturing back in the day in the US, and it was always funny for me because I would leave Australia and arrive in the US before I left Australia, right?
Yeah.
Uh, yeah.
That's
And,
wild. Thank you
look,
so much
and
for having me on your podcast. It's been such a wonderful first honor to meet you because I've been following your research and your care. You're one of the leaders of this airway centric world. So thank you for all that you've done and provided and taught and instructed. And it's been
we'd love
a
to
real pleasure to chat.
well, thank you, but we'd love to organize for you to come and do like a conference here in Australia, particularly on what you just talked about, right? Like,
I would love that.
yeah. Have you ever lectured in Australia? Ever been to Australia?
I have not. I've only ever lectured to Australia virtually. So
Right.
I've got a bunch of courses with the breastfeeding conferences group in Australia and the lactation
Okay.
consultants of
Okay.
Australia.
Yeah. Yeah.
Yeah, so I've had some connections there, but
Right.
have not had the. I actually haven't flown overseas. I've been to England once as a teenager for sports,
Huh?
and that's it. So I haven't yet had my share of travel yet. I've
Right.
been.
Let's see. I mean, I know you have a busy schedule, but you have so much to offer, and particularly the clinical research that um, um, because many people make comments, but if they don't have the clinical research to support it, it's just a comment, it's just an
Yeah,
observation. You have the
yeah,
data,
yeah.
and as I said, thank you very much for allowing me to watch those lectures that you gave to the
Oh,
Ontario
you're
Dental
welcome.
Association. They were so really, really good lectures. I mean, wow.
Yeah, thank you.
So
Thank
yeah.
you.
All right.
And you probably saw it. My first publication was The Tongue as a Muscular Hydrostat that came out a
Yeah.
few weeks back in
Yeah.
IGM. And I've got three more papers that are coming out this year. The one that I just finished writing yesterday is surgical checkpoints and objective measure to know of a completion of a tongue tie release
All right.
to achieve the muscular
Yeah.
hydrostat ability of the tongue. And
Yeah.
then later this fall winter will be the signs and symptoms related to restriction and the improvements that follow in both my infants and then my children, teens, and adults. So by 2026, the hope is that some of these big, sample sizes, thorough comprehensive data are out there that
Yeah.
can hopefully help our airway joined mission, to
Yes.
get this care,
Great.
really at the forefront across the world,
And in fact,
So,
there was one question I was going to ask you again. Just I find,
yeah.
and maybe it's because I'm just looking more often, but do you think there's more and more kids that have lip and tongue ties than we ever saw before?
Oh, I love this question
Yeah.
because it allows me to talk about history.
Yeah.
So
Yeah.
so I would so the short answer is, are there more tongue and lip ties now than ever before? No. I think we are assessing them more now
Yes.
than
Yeah.
we were before. But tongue and lip ties have been around since humans have existed. So,
Okay.
but the fascinating part is that one of the first signs and symptoms related to a tongue restriction are breastfeeding challenges, right?
Yeah. Yeah.
So up until the 1940s, if a baby could not breastfeed effectively, this is
Yeah.
before the invention of bottles and
Yeah.
formula, they
Yeah.
wouldn't survive, right? So
Right.
so
Right.
before the 1940s and before the 1900s, when scissors weren't yet invented, there
Yeah.
would be that people thought it was a myth of that long fingernail
Yeah. Yeah.
of
Yeah. Yeah.
midwives or physicians,
Yeah.
and it was not a myth, it was fact. And
Right.
they would look at the baby's mouth and they would release the restriction.
Yeah. Yeah.
In the 1900s hit, they then used scissors and then beyond.
Yeah.
And that was widely practiced. And that's also during the time where if you were in a community that didn't have that access, you would try, the poor families unfortunately would try to dilute animal milk, but the baby
Yeah.
would be malnourished. Babies wouldn't survive. And then you
Right.
had
Right.
wealthier families, we had wet nurses. You would
Yeah.
hire someone to breastfeed your infant.
Yeah. Yeah.
And then the 1940s hit, and that's when we had inventions of formula and bottles, and women began
Yeah.
working,
Yes.
and breastfeeding rates just naturally declined. So
Right.
tongue tie assessment and release really kind of vanished between
Yeah.
1940s and 1990s. So that's
Yeah.
why anyone that's typically alive right now is born in that bracket.
Yeah.
They could be living with a restriction and have no idea, right?
Yes. Yeah.
Then the 1990s hit, and women were working and they wanted to breastfeed, and we want to do all the things, and that's when the nurses and lactation consultants and you name it were supporting, but they
Yeah.
were still not getting any improvements. So they started looking back inside the mouths and said, "What
Hmm.
the heck is this?" And
Yeah.
then, so phrenotomy sort of reappeared in the literature 1990s onwards. But
Okay.
it's been around. Some will even argue it's been around since the Bible has been written, because
Yeah.
Moses was quoted to have a tongue tie and have a
Oh,
stutter
wow.
related to it. So, like,
Yeah.
if you go back in, pre-medical literature,
Yeah.
tongue tie is regularly commented on. So
Yeah.
it's an
Yeah.
old problem, but we
Yeah.
have new knowledge.
Got it.
Um,
Got it.
and I
Yeah.
and I think people, again, as you said, with social media and parents being advocates, because I think the healthcare system on a whole has become reactive, not
Mhm.
preventive. And
Yeah.
but parents are taking on the preventive role. So parents are really becoming the advocate for their own health, their children's health, and they are the ones that are bringing it to the forefront and seeking care, as soon as possible. So,
Perfect. All right.
yeah.
Well, thanks for that. And
Yeah, you're welcome.
I will
Thank
send you
you.
this, and let's get that invitation. I guess for you, the best time to visit Australia would be in the middle of your winter. You want to?
Oh, I actually love the winter.
Oh, you
So
do.
so yeah,
Okay.
so bring me to Australia when it's I guess the Australian winter, when it's cooler
Okay.
temperatures, yeah.
Yeah.
And
Yeah. Good.
less crowds. Yeah.
All right. Thanks again.
Perfect.
Bye.
Thank you,
Bye.
Dr. Mahoney. Take care.
See you.